I said, "Doc, I have a swollen knee." He said, "Don't wait, aspirate." Today we'll discuss the approach to acute inflammatory monoarthritis, that is swelling in one joint. We will talk about aspiration or drainage of the joint and analysis of the fluid. I titled this talk "The Approach to Acute Inflammatory Monoarthritis," but really the issue is aspiration. If one encounters a swollen acute joint, the first thing that should be done is the joint should be drained and the fluid analyzed. Reasons to aspirate a joint. If there's any monoarticular effusion of acute onset, especially if one doesn't know the diagnosis. We just had a discussion about septic arthritis, and as I stated in that discussion, it is very important to diagnose this and treat that early. If there is an effusion of an arthritis that's not diagnosed, again, to obtain fluid to analyze in order to figure out why they have, or the diagnosis for the inflammatory arthritis. If they have a known underlying arthritis, but there's a joint out of proportion to the other joints, such as a rheumatoid, that needs to be drained and analyzed. And obviously, if there's any concerns at all about a septic or infectious arthritis, such as a tender hot joint, the joint needs to be drained. Now, virtually any joint can be aspirated. What one needs is antiseptic, sterile gloves, and syringes, needles, etc. If you yourself cannot do that, there are people that can help. Orthopedic surgeons, rheumatologists, or even at times those people need help, and we employ the use of radiologists who can actually visualize where they're putting the needle and obtain fluid for us. So any joint could be aspirated, maybe not by you, but by somebody else. This is just an example of a tray that would have the equipment that is needed to aspirate, including betadine solution, sterile gauzes, syringes, needles, etc. Basically, the procedure is the skin is cleaned with antiseptic, a nub or a bleb is put on the skin, and then a needle is inserted in the joint as aspirated. This is just showing an aspiration. Note in the knee that the synovium extends above and below the patella or the kneecap. With a lateral approach, we actually go above or more proximal to the kneecap to get fluid. There's actually a very good discussion by the New England Journal of Medicine authors on YouTube about aspiration, and I've referenced it here in the slide, and I'll actually put the reference below in the discussion of this talk. So after the fluid is obtained, what do we do with it? The first thing to do is just look at it, and indeed a lot of information can be gathered from that. This is a clear synovial fluid. Clear synovial fluid is not inflamed. Too often I get a report from an aspiration by other physicians where they report that fluid was obtained, it was straw colored. That's not that important to me. Rather, what I want to know is whether it's clear or cloudy. And this is just an example of a clear synovial fluid. Note that one can read through the synovial fluid. This is an inflammatory synovial fluid, and note how cloudy that is. This is a purulent synovial fluid. This is most likely a frank infection, although if you look in this, there's a lot of little specks. These are called rice bodies. This is another example of rice bodies in a non-inflammatory effusion. Rice bodies are actually pieces of synovium that have broken off and are floating in the joint. And again, just as a comparison, this is rice bodies, this is rice bodies in a purulent fluid. This is a hemorrhagic effusion, that's blood in the joint. There's a clue as to what's going on here. You can see the blood below, but above there's this white stuff. This white stuff is actually fat or lipid. Fat would find its way into the joint from the bone marrow. So there's been a fracture into the joint from the actually bone, causing a hemorrhagic effusion with the bone marrow on top. And this is just a comparison of the different fluids. This is clear or normal. This is mildly cloudy or mildly inflamed. This is inflamed. This is purulent. And this, of course, is hemorrhagic. Now, in addition to that, one can begin analysis of the synovial fluid even before examining under a microscope. The viscosity can be checked, and basically I take a drop of synovial fluid, I put it on one finger, and then I just pull it apart. And a very viscous fluid, you'll get a string sign, and that can sometimes be several inches. Another thing that can show the quality of the synovium is a mucin clot. And what is done there is that 1 part of synovial fluid is added to 5 parts of glacial acetic acid, which is like vinegar, and what will form is a really tight clot of the hyaluronic acid will form a ball. If there's any problem with the hyaluronic acid, such as inflammation, that ball will be sort of friable and fibrillated. After that, a wet prep may be performed on the synovial fluid. Basically, that's just looking at it under a microscope without any dyes. This is one thing one might see. This is a synovial villus. In other words, the synovium is proliferated, the lining of the joint is proliferated, and parts of that have broken off into the joint space. These are actually fat droplets. Again, we talked about fracture into the joint, and this is what one might see looking under the synovial fluid if that occurs, where you can see the fat droplets into the joint. Without the use of polarized light microscopy, this is a monosodium urate crystal, what we see in grout. It's sort of a long, thin crystal. When we use the polarized light microscope, it'll be much easier to see, and I'll show you that in a minute. These are cholesterol crystals. These can occur in lots of different effusions. Really, they don't show a lot or mean a lot with respect to inflammation. This is ochranotic cartilage from a condition called ochranosis. This is a rare condition of the joint. We don't see a lot of that. And this is a plastic fragment in the joint. One might ask, how can there be a plastic fragment in the joint? Well, if one were to aspirate a prosthetic joint, the joint could be deteriorating and breaking off into the synovial fluid. Now, the next thing we do with the fluid is we do a right stain and cell count. And this really helps us classify the fluids. This is just an example of a right stain. You can see the polymorphonucleocytes and the lymphocytes in the stain. So we look at it to get a cell count and a differential, and with that we can then begin to classify the synovial fluid. Now, as I said, just by looking at it we can begin to classify it. A normal synovial fluid is basically clear, and a mild inflammatory synovial fluid is still sort of clear, although there is sort of there can be some translucence to it, and the fluid is straw to yellow. Now, when we get to a frank inflammatory fluid, which is generally counts of 1,000 to 2,000 or greater, then the fluid becomes translucent to cloudy or opaque. And finally, when we have a very opaque fluid with a lot of purulence, we call that a purulent synovial fluid. This classification schema separates them less than 200 cells per cubic millimeter as normal, 200 to 2,000 as non-inflammatory, 2,000 to 75,000 is inflammatory, and greater than 75,000 is septic. In my schema that I tend to use, I tend to consider less than 1,000 as normal. 1,000 to 50,000 is inflammatory, and greater than 50,000 is septic. Again, in the non-inflammatory fluids, less than 25% of the white cells are polymorphonuclear cells, whereas in the inflammatory and the septic, more than half of them are polymorphonuclear cells. The mucin clot is normal in the non-inflammatory and the normal fluid, whereas in the inflammatory group and the septic group, the mucin clot is very friable. And then one can look at the glucose in all the inflammatory and non-inflammatory synovial fluids, except for septic arthritis. The glucose in the synovial fluid is near what that of the serum is. In the infectious, it is much lower than the glucose in the serum. With the classification or with the identification of how many white cells are in the synovial fluid and the classification of the synovial fluid, that can then begin to help one make a diagnosis. Non-inflammatory fluids, most frequently we see osteoarthritis, although early inflammatory arthritis such as rheumatoid or lupus may have a mild or a non-inflammatory fluid. Other conditions which can cause damage to the joint such as trauma, aseptic necrosis, crystal synovitis that is chronic between flares of the gout or pseudogout can have a non-inflammatory fluid. Now, the place where rheumatologists live most is in the patients with inflammatory synovial fluids. And this is the bulk of the diagnoses that we tend to treat as rheumatologists. This includes things like rheumatoid arthritis, seronegative spondyloarthropathy, such as Reiter syndrome, although these patients can sometimes have synovial fluids approaching what we call septic fluid. Likewise, acute crystal arthritis typically is in the inflammatory group, but can sometimes approach that which we call a septic fluid. Psoriatic arthritis and the other inflammatory arthritis that we treat tend to lie in this category. Now, the septic joint, the ones obviously we worry most about are the bacterial infections. Sometimes we can see patients that have gout or pseudogout or even the seronegative spondyloarthropathies with a very, very inflamed fluid which approaches that of a purulent synovial fluid like we see in a septic arthritis. Likewise, one can have a septic arthritis, and sometimes the synovial white count is not as high as we would see in a septic arthritis. In other words, I've seen patients that have had septic arthritis with white counts less than 50,000 or even less than 30,000. The hemorrhagic fluid group, again, we have to consider trauma when we first encounter it. Patients that have a neuropathic joint, such as a Charcot joint, they're damaging the joint, they don't know it. And when drains the fluid, one can often find a hemorrhagic fluid. Patients that have any type of bleeding disorder, such as hemophilia or on anticoagulant therapy, certainly one can think about these when one has a hemorrhagic fluid. And then, again, cancers in the joint or either cancers or benign tumors such as villonodular synovitis or hemangioma can also cause hemorrhagic effusion. So again, just to reiterate, look at the fluid. You can begin a classification there. Document that in your notes. It's very important. That way one knows, such as myself, if you refer to a rheumatologist, they can look at the fluid and look at your notes and get an idea what you're seeing. And likewise, if there's any problems with the lab, at least you have that documentation. And then, of course, send it to the lab and get the things we talked about. Now, the next thing we do with the fluid is we also do a gram stain and culture of the fluid. This, of course, is very important if we are considering a septic arthritis. And what one can see in this fluid is one can see that there's a polymorph nuclear cell, and there's these, and I think these are supposed to be gram-positive coccus, again showing an infection. Now, this doesn't stain very blue, but it should stain blue. And gonococcus, they tend to have more of a gram-negative coccus, which is these would stain red. The next thing we look at is we examine the synovial fluid. Again, this is a wet prep, but we do it with a polarized light. And basically, there's a polarizer on the light source, and there's a polarizer after the substance in the scope. And those polarizers are set at 90 degrees. Obviously, if they were set at 90 degrees, no light would get through. And what happens is that if there's crystals in the joint, they actually polarize or twist the light so that one can see. Now, this is with a red compensator. It gives a red background, and that can be very helpful when it's parallel to the plane of the polarizer. If it's a monosodium urate crystal, it's parallel, and if it's perpendicular, it's blue. And so these will actually pop out at you when using a polarized light microscope looking for crystals. That's how we examine for crystals. Sort of a Memory technique we use is yellow parallel. Yellow parallel sounds like allopurinol. Allopurinol is a medicine that we use to treat gout. If the crystal is parallel to the polarizer, it will be yellow. And that's a monosodium urate crystal. Monosodium urate crystals are, of course, what we see in gout. Now, when we talked about gout, we talked about the tophus, which is the white, Colgate white toothpaste type stuff that we can express from tophi. And when one looks at it under a microscope, it's actually very pretty. And this is an example of a tophus. You can see that there's yellow crystals, and then perpendicular to the plane of the polarizer, there's blue crystals. It almost looks like a geothermal map. So this can be helpful in diagnostic if you express that and look at it under a polarized microscope. Again, this is just the monosodium urate crystal. And what I like to look for in order to make the diagnosis is the monosodium urate crystal in a white blood cell. And I call this the null sign. It looks like the null sign used in math. That would help me make the diagnosis. Sometimes you find crystals not in the cells, so that doesn't mean necessarily that they have gout as a cause of their inflammation. But if you find it in the cell, you know that you do have gout. Now, these are the calcium pyrophosphate deposition crystals, CPPD. So you can see that they're little rhomboid crystals. They're weakly negatively birefringent, which means when they're in the plane of the polarizer, they're blue. When they're perpendicular, they're yellow. And you have to look carefully for these. A lot of times we won't see these even the first or the second evaluations and have to look several times. So, in conclusion, number one, if you have an inflammatory monoarthritis, don't wait, aspirate. That's the most important thing to remember. Get that fluid out, look at it. That can begin to help you make a diagnosis, and certainly if septic arthritis is considered, it needs to be done immediately. I've just put sort of the list of the things you need, but the other thing that's very important is don't throw the fluid away. A lot of times that happens. It needs to be analyzed. At the very least, look at it. At the very least, look at it, document what you see. Clear, cloudy. Clear, cloudy. That's important to document. But then also send it to the lab. You can check the viscosity yourself without the lab just by doing the string test. We don't do the mucin test a whole lot anymore. It's very important to get a cell count and right stain. We can begin to classify whether it's an inflammatory or a non-inflammatory fluid and the type of inflammation, whether it's just normal, the amount of inflammation might we see with an autoimmune arthritis versus a very highly inflamed joint such as we see in septic arthritis or even gout or pseudo-gout. And of course, we talk about web prep. It's very important to culture the fluid. Depending on what diagnosis I'm going for, if I have just a scant amount of fluid, usually the least I'll do, if I don't have enough to do all these things, is I'll culture it so that I can see if there's an infection. Again, document what it is. This is one of the most important lessons that I feel that I treat medical students. A lot of what we discuss in our other lectures will be forgotten, but any fluid that's seen needs to be obtained, needs to be studied, and there needs to be documentation on the chart of what that is. That's important if you're in rheumatology, general internal medicine, family practice, especially orthopedics, especially orthopedics. Too often I've got notes back from the orthopedic surgeon, straw-colored fluid. I don't need that. I need to know inflamed or not inflamed, cloudy or not cloudy, clear or cloudy. That's the conclusion of this lecture. Thank you for listening to this talk today. Don't wait, aspirate.